Welcome to the virtual family council meeting. My name is Jamie Rose. I'm your virtual meeting coordinator. We're going to review our confidentiality reminder at this time. Please refrain from using the name of your loved one. Do not name specific facilities. Please use a nursing home or the personal care home to present to the group. If you need specific assistance, please use the chat feature to state which county you are in, and we will get you connected to your assigned ombudsman. And just a reminder, these calls have public access and are designed for family members and friends of residents in long-term care facilities. Our meeting agenda this evening, we're going to get our virtual meeting tips from Jay, and then we are going to watch a presentation from Dementia Friendly PA entitled Recentering Sex and Sexuality for People Living with Dementia. And then we're going to wrap up our meeting with upcoming meeting topics. So without further ado, I will pass it over to Mr. Rods.
Thank you, Jamie. Good afternoon, everybody. You've all been placed in mute upon entry. We will open the lines in a bit so that you're able to share. If you'd like to speak or have a question, please use the raise hand feature. Once you raise your hand, we will know to acknowledge you and unmute your line. The chat feature is at the bottom of your screen. If you have a question for the presenter, please message the chat moderator and they'll ensure your question is asked. If you need to step away, you can stop sharing your camera by clicking on the camera icon. That's also at the bottom of the screen. You can click on it again to start sharing your camera again. And finally, concerns or questions can be directed to me at the State Ombudsman Office. My number is 717-783-8975, or by email at capital LTC-ombudsman@pa.gov. Jamie, back to you.
Thank you so much, Jay. At this time, we're going to convert over to our video. So give me just 1 second.
Hello and welcome to the first webinar in the Dementia Friendly webinar series focused on recentering sex and sexuality for people living with dementia. My name is Annalise Perry, and along with my colleague Stacy Bonenberger, we serve as the statewide coordinators for the Dementia Friends Pennsylvania and Dementia Friendly Pennsylvania initiatives, which are programs of the Jewish Healthcare Foundation. Next slide. Now, if you are not familiar with either initiative I just mentioned, you may be curious as to the difference between Dementia Friends Pennsylvania and Dementia Friendly Pennsylvania. Dementia Friendly and Dementia Friends are both global initiatives, and in the United States are known collectively as Dementia Friendly America, a program of U.S. Aging. We are grateful to receive support and funding through the Pennsylvania Department of Aging. Dementia Friends focuses on change at an individual level. How can I make a difference in my community by increasing my knowledge and awareness of dementia? Community members attend a 60-minute information session provided by a Dementia Friends champion with the goal of understanding 5 key messages, learning how dementia affects a person, communication tips, and how each of us can make a difference. The curriculum is available in 10 languages and includes all ages, elementary school, middle school, high school, and adults. Dementia Friendly Community Initiatives, so Dementia Friendly Pennsylvania, focuses on change at a community level. Now that we have individual knowledge and awareness, how can we change our community? Many definitions exist for a dementia-friendly community, but they have the same common elements of engaging all community sectors, decreasing stigma, and increasing opportunities for meaningful interaction. Next slide. In Pennsylvania, there are 8 communities recognized by Dementia Friendly America. You can hit, thank you, who are engaged in a process to become more dementia friendly. Dementia Friendly Pennsylvania is honored to be able to support their existing efforts by fostering collaboration among the communities and elevating their remarkable work, all of which is volunteer driven. If you are interested in learning more, please contact us at info@dementiafriendlypa.org, or next slide, please. As of today, you can visit our website, www.dementiafriendlypa.org. Here you can find resources, upcoming events, and learn more about the dementia-friendly communities existing in Pennsylvania. Please note the site is still evolving, so be sure to stop back over the upcoming weeks as more information is released. Next slide. We are honored to introduce our speaker and colleague, Emily Franke. Emily is a licensed social worker with a Master of Social Work from the University of Pittsburgh. She holds dual bachelor degrees in psychology and gender, sexuality, and women's studies from the University of Pittsburgh. Honed through positions as an outpatient therapist and inpatient social worker at a psychiatric hospital, Emily has extensive experience in caregiving issues, sex therapy, and older adult psychotherapy. Emily's therapy practice incorporates a mix of cognitive therapies and mindfulness with a feminist approach. In addition to her therapy practices, Emily's role at the Jewish Healthcare Foundation focuses on aging initiatives. Welcome, Emily. We are excited to learn from you today.
Thank you so much. And I'm excited to be with all of you today. So we will be talking about recentering sex and sexuality for people living with dementia. And just in case you logged on to the totally wrong webinar, we will be talking about sex. So there will be images of intimacy, discussions of sexual pleasure and sexual expression. So here's your chance if you need to pop on headphones or quickly log off of Zoom. Here's your moment, and we'll dive right in. So today we're going to cover a really broad range of topics, and honestly, we could probably spend several hours together if we were really going to get into each of these and give them all their due. So I hope that this will be the first of many conversations that we get to have regarding dementia and sexuality, and also aging and sexuality. But today I would like to frame these things for you with a sex positive approach so that you all leave feeling more prepared to talk about sex and sexuality with people who are either aging or living with dementia. And one final note, I know a lot of you are coming to us with specific interest in nursing home settings, and all of what I'm going to cover today certainly applies to nursing homes, though the ethical considerations that you might want to make in a nursing home is a whole different webinar, and we are happy to dig into that. But if you have any specific questions, pop them in the chat, and if we have time at the end, I'm happy to answer those. So getting started. I think it's important that if we're going to be responsive to the problems that are arising for people, we need to understand their entire identity. And intersectionality is a prism for us to look at identity factors and really make sure we're appreciating how all of these things and more than what's on this list might impact someone's lived experience. And today we'll be looking and talking a lot about gender identity, ability. Living with dementia impacts a person's ability, sexuality, and their age. Essentially, this framework is a really fancy way of saying everyone's unique. And with that uniqueness, we need to make sure that we're tailoring these approaches to suit the individual and to really work for where they're at. So take a moment. You don't have to put anything in the chat. You can close your eyes if you want. What do you think of when I say sex or sexuality and intimacy for people with dementia, people with older adults? Maybe you think of something cute, or grandma and grandpa holding hands, maybe something a little like this, right? Cute. I wonder, did you think of something like this? Or this? So there's a broad range, like everyone else at all points in life, of how older adults and people living with dementia express their sexuality. And we've really narrowed in our culture what that expression looks like. So taking a sex positive approach, I think, really encourages us to look at all forms of sexual expression, all the people who express themselves sexually, and break down some of the taboos and stigma that exist. And I will say most of the images I'm using today are from a really lovely series that came out of the UK called The Joys of Sex in Later Life. And I selected this series because it was done with consent of everyone participating, and they interviewed all of the couples about the experience of being photographed and their take on sexuality. And it was just a really great advocacy effort. And while all of the adults pictured are older, I'm aware that not all adults living with dementia are older, but since we can't say what a person living with dementia looks like, this was my easy out. So I hope you enjoy the pictures as well. So to kick us off, sexual citizenship essentially bridges the domain of sexuality between the private and the public spheres. People have the right to freely express themselves sexually and should be included in institutions. This means governmentally and also institutions where they might live, like nursing homes. And the goal of a society that really celebrates sexual citizenship would be to allow diverse people to take responsibility for their own sexual lives and live in a way that is fulfilling for them. And so regardless of age and access, the control over one's sexuality and sexual expression is key to this. And I think it's an area that, as especially a Western society, we have a lot of work to do. So to start off with the changes, I think everyone has heard a lot about how awful things get as you age and all the terrible things you can expect to happen when it comes to sexuality. However, this is a myth. So while it is true that you might experience difficulty maintaining an erection if you have a penis, or find that vaginal lubrication is not occurring like it was when you were younger, or that more time is needed in order to achieve orgasm, those things don't necessarily have to do with age. More often than not, it has to do with health status. It could have to do with medications, but these are things that normally occur over the aging process and can be modified. So it does not make sex impossible. And frankly, it could make sex more fun, especially if you are willing to experiment with lubricants, sex toys, there's bolsters, there's a lot of options out there. Along the same lines, there are changes that happen with dementia and sexuality. Depending on the parts of the brain that are affected by the type of dementia, you might see a wide variation. You might have someone who doesn't experience a lot of changes to someone who experiences quite a bit of disruption in this area. You see this a lot with frontotemporal dementia, FTD. So since that affects a person's inhibitions, their sexual behavior, their attitudes towards sex might be remarkably different than it was before they received the diagnosis. So these changes that are listed here can vary so widely from people, depending on their diagnosis, depending on where they're at in the disease process, that it's hard to say this is what you can expect. These are just some common things that people observe. The most common thing I think we've all heard is hypersexuality. In dementia, specifically Alzheimer's type, I think we hear a lot about. It's a complaint in nursing homes or other communal care settings. Interestingly enough, a study showed that it was actually only 1.8% prevalence when you actually broke down the behaviors and things that people were seeing. But I think since it brings in other people into the picture, it can be, more noticeable than other behaviors. And hypersexuality or changes to a person's sexuality or sexual expression is not a problem. It's not inherently a problem unless it causes them distress or if it puts other people in danger. And with these behaviors, undressing, masturbation, making unwelcome advances, it's always important to look for underlying causes for that, the same way you would consider other behaviors. So if someone's undressing, is it hypersexuality or are they perhaps too hot? And the best way for them to address that is to undress. Masturbation occurring in public spaces, there's nothing wrong with masturbation. So cueing someone to find a more private space, helping them find that private space versus trying to say, don't do this behavior, that redirection will probably garner better results than just trying to take away someone's right to express themselves sexually. And these tips, I will say, work for individuals. If you are a care partner for someone living with dementia, or if you're an advocate or a provider, these are great things to pass along to people who are finding changes come up. And exploring new ways of spending time together, we'll get into different types of intimacy a little later on, is I think the time together piece plays a big role in intimacy. So being open to trying new things, not just sexually, but just trying new things in general with your partner can help make people feel comfortable together and maybe more open to talking about things. Other ways of showing affection, not all touch has to be sexual touch. Hugging, snuggling, holding hands are all ways to be intimate with someone, to have that comfort of touch without being sexual. Massage, dancing, and again, we come back to masturbation. This applies to both people living with dementia and care partners. I think this is an area that, depending on generationally where people are at, might be really taboo to talk about, but is certainly a way that if someone's interested in exploring, giving them resources or affirming that it's okay if that's something that they're feeling interested in doing. The good news, like I said before, that dementia and aging does not mean it's the end of someone's sex life. And in fact, a 2018 study found that of those people living with dementia at home, 59% of men and 51% of women were still sexually active and sexually fulfilled. So I think those are excellent numbers and very important to keep in mind as we think about that's living at home, translating those numbers into a nursing home. We're not there yet for sure. So how might we do that is the question. Benefits of sex. I don't think we talk about the benefits of sex enough. We talk about all the things that would change, but not all of these wonderful things that you can expect to get out of sex at any age. It's not something that just applies to young people. It's not something that just applies to older adults or people living with dementia either. These are across the board. And this lovely couple that we see pictured here had this to say about having sex as you get older. And I really like that the intimacy and love that a couple shares shines through. That barriers certainly will come up, and it really comes back to that tie between people as to how they overcome them. So let's talk about it. As providers, it is a provider's responsibility to initiate the conversation about sex. This means both assessing for any sexual issues and sexual pleasure. Not something I think many of us can say a doctor has asked us of, are you having sex? Is it good sex? Do you have any pain with sex? Those kind of follow-up questions are really important. Due to these numbers, more than 30% of men and 10% of women reported concerns regarding sex. Of those, only 17% of men and 1% of women have talked to their providers about sex. So huge difference there. And 60% of people over the age of 65 aren't comfortable talking to anyone about sex. And I've heard this multiple times from clients and people I've worked with in the hospital that sometimes their partners are actually the ones that are the most difficult people to initiate a conversation with, because saying something's changed, they're afraid might be translated to, I'm not feeling the same way about you. You've changed and this is different. And that fear of rejection is huge. So avoiding it altogether ends up being what happens. And people commonly say they're embarrassed, they don't want to make other people uncomfortable, they don't know when to bring it up or how to bring it up. And while this is specific to people over the age of 65, there's similar percentages for people who are living with dementia. How do you bring that up? How do you frame that in the context of health issues? And this is why I think for providers, initiating that conversation is very important. And a tool why I think for providers, initiating that conversation is very important. And a tool to do that is this framework, ask, tell, ask. So it's very simple. If anyone here has worked with end of life issues, it's commonly used to talk about terminal diagnoses. It gives people time to kind of process the information you're giving them. So asking for permission to talk about sex, saying something along the lines of, you know, you're here today to talk about the medications you're on. I just also like to talk about the sex that you might be having with your partner. How are you doing? I want to talk about this because I know that medications can cause some issues with sex, and I want to make sure that if that's happening, you feel like you can talk to me about it. So I've asked for permission. I've told them why I want to talk about this and why it's important. And I might say, what are you noticing? And that's key. What are you noticing versus, are you having sex? Or are you having any issues? No, you're having sex. What issues are you having? That opens the door. Someone can always say, you know, I don't want to talk about this. I don't feel comfortable. But by opening the door and saying, I'm going to assume that you want to have this conversation, I'm willing to have it. It breaks down that barrier. It shows that you don't have this idea that people living with dementia or older adults are asexual, not having sex, and therefore it is not your problem. This framework, ask, tell, ask, is also an excellent way for people who are older or living with dementia to talk about sex and sexuality with their healthcare providers. In the same kind of way, you can ask if it's okay to talk about it. You can tell them what's going on, and then ask if they're open to talking to you and how they feel about having this conversation. And if a provider says, you know, I'm not really the one, they should be able to direct you to other resources. And at the end of this presentation, I have a bunch of resources, but I will say, I've also heard, yeah, I asked my doctor and they just sort of shrugged. They didn't know who I could talk to. And in the day and age of Googling, I'm sure we could all turn to our computers and start to figure things out. But if doctors can't answer the questions, you know, go to the nurses, go to, if you have a care planner, a discharge planner, a social worker. Sometimes it's outside of that direct care provider who can give you some insight. But this is an excellent framework and it's easy to remember. For care partners, having the conversation with their loved one living with dementia can trigger a lot of feelings: frustration, guilt, anger. These are all very normal, and I'm sure come up in more areas than just talking about sex. And it's important to have the conversations, though they might trigger these emotions. I always advise my clients to do things like use I statements. So saying, for example, I feel worried about my lack of desire and that it might be perceived as lack of desire for you, rather than a result of my diagnosis, or if you're a care provider, rather than for, you know, my stress and how it's really hard for me to get turned on right now, versus you make me feel guilty for not wanting to have sex with you. The I statement, again, opens that door. The you make me feel statement puts up a barrier. So care partners, it's important to hear it's okay, it's very normal, And like I said before, the most uncomfortable conversation might be talking to the person who you'd like to be intimate with about this. Turning to family, friends, advocate support, a therapist are all really good places to also start. There are some specific forums out there for these topics. And if you have an established relationship with a support group, you can always float the idea of talking about sex, and that, I would say, ask, tell, ask is also a good framework to use when seeking permission from a group to broach the topic. And for care partners and people living with dementia, older adults, really anyone here on this call, the 3 T's are things to live by: time, talk, and touch. And when you're facing difficulties in a relationship, more time, more talk, more touch. Time referring to the initiation of intimacy over a longer period of time. So our sexual cycles, think of it like a 24-hour clock. If you were really stressed out yesterday, it might still be hard to feel in the mood to initiate and relax into a sexual experience today. Our brains don't just overnight get rid of everything. And contrary to popular belief or what you might have seen in the movies, your brain is your most important sexual organ. That's where all desire and arousal starts. And so it's important to give yourself time, give your partners time to build both emotionally and physically with foreplay. And this last one here is maybe most important, to focus on connection and not performance. So going into a situation and saying, there is a goal here. My goal is to orgasm, or my goal is to have sex. You're setting yourself up to either experience frustration because there was failure of that goal, or to be pressuring someone with this sort of like, thing out in the distance that we're working towards. But if the goal is, I want to be connected with you, I want to spend time with you, then if even you cuddle for a few minutes, that's a win. Talking, again, wide range of activities. It could be talking about sex. It could just be time to talk about how you're feeling, and discussing your concerns can be a part of that. It could be talking about how to overcome those concerns. And the more talk also applies to medical providers. So like I said, your brain is your most important sexual organ. So knowing what's going on, what medications might be affecting you, if there's anything else out there that can support you, your medical provider is a great place to start for that. And touch, more touch in all forms, sexual, affectionate, and how you might incorporate affection into instrumental touch, I think is very important for care partners. So if you're helping someone bathe or get dressed, how can you turn that instrumental touch of helping into affectionate touch? Is it a shoulder massage? Is it a hug? Adding those things in can make a world of difference. In this quote, people living with dementia have a sense of guilt and burden. They may find intimacy in other ways if sexuality is not a place of comfort. So for some people, there is very little interest in expressing sexuality through sex acts, and that is perfectly okay. There's a lot of different types of intimacy. I think generally we all go to physical intimacy, right? It's sexual touch, it's holding hands, it's hugs and kisses, cuddling, and these things are very important. And in fact, physical touch, physical intimacy is correlated with high relationship satisfaction. However, it's not the only one. And certainly we cannot say the most important one, because this will vary between couples, between people. And you can have intimacy with people who are not your romantic partners. So you might have a high level of emotional intimacy with your best friend. There's connection, there's vulnerability about how you feel. You might not have physical intimacy with that person, right? So these are things you might have across the board in your relationship with your partner, or you might find connection and intimacy with a lot of different people in your life. And working these into relationships is really important when you're thinking about the changes that might occur. And especially if you have a loved one or you yourself are admitted into a nursing home and are looking at that change of environment. Physical intimacy might be more difficult due to the communal nature of nursing homes, due to strict policies that are in place, and oftentimes that is just to avoid liability. So how can you find other ways of connecting with your partner? Emotional, spiritual, intellectual, social are all ways that you might be able to find sustained intimacy. And the role of the advocate. I know we had a lot of ombudsmen sign up today who are interested in learning more about how they can be of assistance, how they can advocate for people who are in nursing homes. And really, I think everything we've talked about, initiating conversations, breaking down those stigmas, opening the door for people to talk to you and know that it's a non-judgmental, safe space is more important than any legalese or documents or fights that you can have for them. It's making sure that they feel heard, that their opinions are respected and appreciated, and ultimately that they are heard by you and maybe translated by you to the nursing home or the people around them. Because just working with older adults, cute, they're so cute together is a thing that I hear a lot from very well-intentioned staff. And what they're not realizing is how demoralizing that can be to someone who's an adult, who's really interested in having an intimate moment. It's not cute. We don't want to be cute in those moments. So knowing some of those triggers and hearing from people what their individual triggers might be. This ties in with consent. So we're transitioning into considerations of consent now. The difference between competency and capacity. I hear these two words thrown around a lot interchangeably, and while they're related, there is a finite difference here. So competency is whether a person is legally able to manage their affairs and make their decisions in a legal setting. The court has to determine this. So someone can't come in and say, you're not competent, you can't make your decisions anymore. It has to go all the way through the legal process. Capacity, however, can be determined by a physician, and this is a comment on someone's decision-making ability, and it's based off of, do they have awareness of their personal values? Are they able to comprehend the situation, the thing they're making the decision about, and are they able to express understanding of that? Just because someone is deemed incompetent under the law or incapable by a physician does not mean that they cannot make their own decisions. I think when we talk about sex, you know, we say, oh, well, if they're not capable, they don't have capacity, then how can they consent? Well, how are they consenting to eating chocolate pudding versus vanilla pudding? They still know themselves, they still have a choice, right? So as we help people make decisions, this framework for decision making, a lot of words on these slides I think will be available. Stacey and Annalise can correct me. This framework is very important and it should be very helpful. Assuming that everyone has, not a thumbs up, so you will get these slides. Assuming that everyone has capacity. Every adult has the right to make their decisions. This is regardless of age or mental status. If someone is deemed not capable, we need to be very, very careful that we are not saying, it's not what I would do, or I don't feel comfortable with that, and saying, therefore, that's a bad decision. And we do not want this person to do this. So it comes back to, are they in danger? Are they putting someone else in danger? Not my comfort level. And this is very much a gray area because everyone has a different set of morals. We can go back to that intersectionality approach. Caregivers, people working in nursing homes, all bring their own views into these situations. And ultimately, it really needs to come down to the best interests of that person. So supporting individuals in making their own decisions, still means if they've been deemed incompetent or incapable, and always choosing the least restrictive option. So if someone is expressing the desire to masturbate, but they have trouble making a decision about where to do that, and therefore putting other people in an uncomfortable situation, then we need to choose the least restrictive option to get that person into a private space. This is an example I used earlier. That does not mean no more masturbating for that person. It's a redirection of the behavior so that everyone is safe and you're not taking away that sexual citizenship from the person who's interested in expressing their sexuality. So it comes down to empowering people and being flexible, because each person is going to be different and the process of this is going to be different for everyone. So along with capacity, as I mentioned, we get into consent. And consent is something that is constantly evolving. I know through my time in undergrad, there's been numerous ways of framing this. No means no, it's on us. I'm sure you've all seen the campaigns. And when it comes to drinking and consenting, a drunk person cannot consent, right? We know that. A person who is unconscious cannot consent. When we take those rules and say, okay, we need verbal, explicit consent, we're not considering the people who might not be verbal, right? The people who can't verbally say yes. So I'd like us to think of verbal and nonverbal ways of consenting. These should still be explicit. So, if I'm non-verbally consenting to something, it's not, you don't know what I'm doing, right? It's very clear that I'm consenting, in the same way that saying that sounds great is very clear. Pulling someone closer, actively touching someone, initiating sexual activity. Do you hear gray area? Because that's what I hear when I get to those things. Again, case by case basis. Unfortunately, there's not a golden rule that we can follow across the board. So again, going back to, is it hypersexuality? Is someone pulling someone closer because they need something, there's an unmet need, or because they would like to initiate sexual contact in some way? We can use context clues for this. So considering a person's past regarding their sexuality and sexual expression, was that person always kind of touchy-feely, and are they reaching for their husband and pulling them closer? That might cue us into, here's someone who's consenting to sexual contact, or at least to touch. This is not easy. This is probably the most difficult part of this whole conversation. And this case example might help us explore a little bit more. So I'll read it out loud. 2 nursing home residents, one living with dementia, have been dating for some time. They both lost spouses and have adult children, and staff find that over time, this couple is interested in sharing a bed together, and the staff report that the situation is unsafe. They go to social work and they say it's unsafe because these 2 people have physical impairments. Them trying to get into bed together, someone's going to end up falling. It's not safe. So social work's discussion uncovers that couple would like to spend some time cuddling. They can't get into bed together safely, but they don't really feel comfortable asking staff. And staff have been supportive of their relationship. It's very cute when they sit at the nurse's station and hold hands. But staff aren't sure that they're fully comfortable helping 2 people get into bed. The solution was social work counseled staff on, you don't need to stay in the room, you don't need to monitor, you don't need to, take anyone's clothes off. All they're asking for is to safely get into bed together. These were 2 adults who were able to consent to this. And the fact that one of them needed a Hoyer lift to get into bed is just where things were at. So the staff ultimately were able to ask after dinner each night, would you like to spend some time in bed together? And sometimes they said yes, and sometimes they said no. I would say this is a successful navigation of the situation. The one thing that I did not include here is that the administration at the nursing home said, you need to call these two adults, have adult children, you need to call their adult kids and tell them that they want to be spending time cuddling together. Social work pushed back on this and said, you know, where's the line? Where's the privacy here of, you know, we can guarantee that they have a nice private place to be together. Do we need to let their adult children know? Ultimately, they called the adult kids and the adult kids said, why are you telling me my mom wants to be in bed with a man? I don't care. Let her do what she wants to do. Certainly that is not how all families react, but it is important to remember that if you're working with people who are giving you verbal consent, you are working with people who you can assume have capacity. They have not been deemed to not have capacity. And this is the least restrictive option for them, then that's the way to go. I'm sure, Ombudsman, you've gotten every variation of that call. I'm sure you've gotten situations that were maybe dangerous and had to make some serious considerations as to how to navigate the safety concerns. But coming back to case-by-case basis, lots of conversations is the way to go. One thing that I don't have here in the slides, but I think is an interesting direction that the field seems to be going is the exploration of the use of sexual advance directives. So I'm sure you're all familiar with a classic advance directive, which says, you know, I would like to donate my organs. I want, you know, this type of treatment, but not that. Adding in a sexual component. And it's a very interesting legal conundrum. Can you preemptively consent to sex? I see it as potentially a vehicle of conveying an okayness with, okay, if I, through my dementia process, find that I'm attracted to someone and would like to spend time with them, I want efforts to be made for that relationship to be respected and upheld, even if that's not with my spouse who's still alive, right? Interesting. Right now, advance directives are not enforceable under the law, so adding in a sexual component, how does that work? But there's a lot of really sad cases of spouses of people living with dementia being prosecuted for sexual assault and rape because they've engaged with sexual acts with their partners. And under the law, the assumption has been there's no way that that person living with dementia can consent. So it is certainly a gray area and depends on the state you're in, depends on sort of the way it's reported up the chain if it goes to police. But the proposal of advanced directives that have that sexual component could potentially avoid some of those scenarios. So some food for thought there. I have just covered a lot of information in a very short period of time. So hopefully we have lots of time to maybe answer some questions. And I will say, since these slides will be available, there's some resources here if you'd like to learn more about anything I mentioned today. One thing that I will draw anyone interested in nursing homes and sexuality to is the sexual assessment tool for residential aged care facilities. Language is a little bit different because it's from Australia. So they are residential aged care facilities, not nursing homes, but same. It's a very interesting assessment. I encourage you all to look at it and realize how far maybe we have to go, because of the nursing homes I know, not a lot of them can say yes to many of the things in this tool, but all of these are links and are available for free online. And with that, Stacy, Annalise, I'm not sure if there's any questions in the chat, but I'm happy to answer any.
Hi, everyone. We really have not had any questions in the chat. I think your talk has been very thorough. Actually, we have Judith, if you want to unmute, go ahead and ask your question.
Yes, thank you so much. My question is for early stage of dementia, and I see couple of people now, they start to date online.
Mm.
I would like to, your insight or your input, or if you have this experience.
Yes. A very interesting collision of realms, right? Online dating, dementia diagnosis. I would say early stages, someone's making the effort to put themselves out there. Really, it comes down to that person as to how they want to navigate. I know the biggest dilemma there, I have heard of this before and encountered it, is do I tell people that I'm dating, that I have this dementia diagnosis? How do I tell them? Will it impact their attraction to me? All of those things, right? And the answer is it's up to the person with the diagnosis to decide when or if they tell people. Obviously, if you're entering into a long relationship or an intimate relationship, I would say it's probably a good idea to be upfront, just so that the other person has the ability to make decisions. Again, to go back to the consent thing, make sure that they're seeking that consent in a way that's respectful of the person with the diagnosis. But it's not uncommon that I think people hold back that information initially, and I think that's okay. In the early stages of dating, you're trying to figure out if, you both like the same sports teams, right? So no need to go into health issues until it's progressing. For providers, I would say there is a safety concern of just making sure that the person living with dementia is able to continue to make good, safe decisions. I feel like my mother, but the internet has a lot of strangers, a lot of bad people out there who can pretend to be anyone, yada, yada. So I think all of those safety concerns also apply to that situation.
Emily, we had a question about, a really good question about STD resources for older adults. There also is in connection with a program that's being designed for LGBTQ plus older adults, and wanted to make sure that they had adequate resources to share.
Wonderful. Yes, I did not include any specifically in this, but I do have several in that realm related to LGBTQ and STI, STD prevention. When you take pregnancy out of the picture in heterosexual relationships, there's, I think, a very quick assumption of we don't need protection like condoms, we don't need testing. Simply not true, right? Especially people who have maybe been with partners for years, and if you both had herpes simplex 2, 1, you didn't think so much about it. Have a new partner, new testing. Unfortunately, there's not a ton of resources out there specifically for education. There's a lot of calls for education. For LGBTQ older adults, SAGE is always a great organization to look for resources from. And I believe the CDC has started to push to say providers need to be assessing for sex between new partners, regardless of age. Though, again, we have providers who have their own ideas about sexuality and aging, so there might be a barrier to overcome there. But I will be sure to pull up some of those resources, and you can find them on the website once everything's posted.
Okay, next question. It's a hot topic. I had previously worked at a facility that had a dementia unit. Male and female residents both lived on the unit. Residents specifically would seek out each other and wanted to engage in underclothing touching. Both were married to other people. How would you handle this scenario? Any tips?
So it sounds like both people are consenting to this touch. I'm going to assume that if their spouses came in, this wouldn't be a thing that they would be thrilled to see. Funny enough, I was just talking to Annalise about a very similar scenario. She's comes from, I'm outing you, Annalise, a nursing home background and as an NHA. And, there's the people involved, the 2 people living with dementia, we've established they have consent, they are making these decisions, they're on board. Spouses sound like the hang up here. So having a conversation with the spouses might be necessary, especially if they're coming in and they're seeing that, you know, their wife is now trying to go to someone else. They're saying, what's happening here? Psychoeducation on the changes that happen in the brain, that disease process, is really, really important, because we talk all the time about all the other changes you can expect and kind of gloss over some of the sexual changes. When you add in, if those two people were maybe not always remembering who their spouse was when they came to visit, becomes a little bit more of a tricky area to talk to that spouse about. Redirection, I would say, is another good place to start. So you educate the spouse and then redirect the residents. Maybe that means when the spouses are coming to visit, you say, hey, do you want to go out in the garden? Do you want to go into a private space? That then it's not putting that resident in a situation where now their spouse is going to be upset because they're gravitating towards their new interest. So redirection, education for the spouses.
Here's an interesting question. Do you have any tips on how to best indicate to someone that you are a safe, judgment-free listener if they want to talk about anything about their sex life or sexuality? It can be tricky to get over those initial taboos.
Absolutely. Well, what you just said there, you are a safe person. It's hard to illustrate to people, especially when you're just meeting them, of, you know, we can all give the lip service of, you know, I'm a safe space, I'm here for you. So having that conversation, be explicit, say, you know, I'm here for anything you want to talk about. Give some examples of what those things might be. Oftentimes saying like, well, we could talk about sex if you wanted to, versus I've had conversations with people about sex before, and while I don't always have the answers, I'm always happy to talk about it. And if I can't answer your questions, help you find someone who can. Do you want to talk about anything? Something like that, of giving, again, opening the door, opening it wide and explicitly to say, I'm willing to do this. Here's how I might help you. Here's how I might be able to have a conversation. Especially if your role is maybe unclear to people. So ombudsman, I'm sure all the time, people are like, who are you? Why are you here? Why are you talking to me about this, right? So framing for them how you can help, why you care about this topic, why you care about talking to them, then makes it not feel so much like a test, or like, you know, you actually secretly might be there to judge them or get them in trouble. So explaining and person-centered, meet people where they're at. So if they're cognitively not in a place to take in all that information and they have a really concrete problem, explain how you can help them very concretely with that one issue. You don't have to open the door and say, we can talk about anything. Just talk about that one thing.
So our next question, you may not be able to answer. It's a pretty regulatory question, but I wanted to put it out there because maybe someone else on the call, if you don't have any information, would be able to address it. It may be more DOH, DHS question, but it's a good one. Is it required for nursing homes to provide condoms and dental dams for residents if requested? Or do nursing and personal care policies not allow that to be provided?
That is a fabulous question. And to my knowledge, required, no. I don't believe those would count as medical necessities, things like that. Though I would say, for me to be totally confident in that, we would have to go look at the regs. If anyone else has insight, feel free to unmute and let us know.
I just wanted to chime in and say I would agree. I think it's something that it's kind of that intersection of residents' rights versus, you know, regulations. And so something we could certainly take to Department of Health or Department of Human Services to look into that further.
And I would say one of the keys to creating stigma-free spaces is to talk about this. One thing we didn't talk about and would be a whole hour-long discussion is LGBTQIA, older adults who are aging and living with dementia, moving into nursing homes. There's a phenomenon called re-entering the closet, where your identity is not talked about. It's not on the assessment forms to say, you know, how do you identify your gender? How do you identify your sexuality? And by not asking, I think nursing homes, personal care homes, assisted living facilities assume that they're respecting people's privacy. But again, you haven't opened the door up, you know, for people to tell you, here's how I identify. I want you to know that that's an important part of me. So some of the initial efforts to overcome that have been to say, talk about it. Because don't ask, don't tell is the policy that we know didn't work. And that's unfortunately how a lot of nursing homes, really any community, how they tend to work. And I think condoms fall into the same area there.
So I will say that is the end of our questions. We do have a few closing slides that Annalise is going to go over. I did want to say, if anyone has suggestions for future topics, please put it in the chat. Even if it's to expand on anything that Emily, you know, brought up and you want to hear more on, or, you know, completely different topics. Really, Emily, thank you so much. And I'll turn it back over to Annalise. And we're so happy you all were here.
Thank you. And here we go. Thank you again, everyone, for attending. And yes, thank you, Emily, for providing such an outstanding presentation. We hope you can join us for our next dementia-friendly webinar on April 4th on dementia and firearm safety, where we will have a keynote presentation followed by a moderated panel. I believe the link to register is going to be placed in the chat. If you would like to stay up to date on future webinars and other news, we do encourage you to visit our website, again, www.dementiafriendlypa.org, to join our mailing list and just keep in the know about what's going on. Last slide, please. Okay, so if you are interested in learning more about what it takes to become a dementia-friendly community within the Dementia Friendly America Network and how we as Dementia Friendly Pennsylvania can support you, we encourage you to attend one of our upcoming dementia-friendly community workshops. The same material will be presented on both dates, so you need to only register for one. And again, you can find that on our website under calendar and events, or hopefully I know it's being placed in the chat. I did have a request. Someone did just send a chat. I believe someone asked if you could put up the resource slide again. We're happy to do that. This does, though, conclude our dementia-friendly webinar. We hope you all have a wonderful rest of the day. We will take the recording and we will take the slides. We will make sure to send an email out following this.
Alrighty, that concludes our presentation. I will share our upcoming meeting topics. As you can see, we don't have any scheduled just yet. We are taking all of the answers that we got from the survey, and I wanted to thank everyone who took the time to really provide a lot of insight and topics that they would like us to review for that. So we're going over those and we're scheduling upcoming speakers. So keep an eye on the Facebook page and we will be sending out email reminders. Our next meeting will be March 21st. And we will let you know who we confirm for that slot as well. And of course, thank you so much for attending. If you have any specific questions, please reach out to the State Ombudsman Office at 717-783-8975 or give Jay an email, ltc-ombudsman@pa.gov, or on the chat area of the Facebook page. And I will have this recording available on Facebook and YouTube by the end of the night. So thank you everyone for joining.